Hi, everyone. Thank you for being here. It's the top of the hour, so we'll go ahead and get started. My name is Nicole Wake, and I'm the current chair of the RSNA 3D Printing Special Interest Group, or SIG. I'm delighted to have with me here today Dr. Wilson King, a pediatric cardiologist from the St. Louis University School of Medicine and Cardinal Glennon Children's Hospital. Dr. King specializes in cardiovascular magnetic resonance, cardiac computed tomography, echocardiography, and pulmonary hypertension in children, and his services include treatment of a range of pediatric cardiovascular conditions. So thank you for being here, Dr. King. Before we get started, I just wanted to provide a brief overview of the RSNA, which is the Radiologic Society of North America. It's a nonprofit organization with over 52,000 members from 153 countries around the world. And RSNA's focus is to promote excellence in patient care and healthcare delivery through education, research, and technologic innovation. And we're part of the RSNA 3D Printing Special Interest Group, which is a group of people within RSNA working on 3D printing. And the mission of the SIG is to promote the highest quality research or 3D printing applied to medicine via education, collaboration, and research. And this year's leadership, so I'm the chair currently, and we have Dr. Lou Marie Santiago as our vice chair, Dr. Beth Ripley is our secretary, Dr. Summer Decker is our treasurer, and Dr. Ken Wang is our liaison to the Radiologic Informatics Committee within RSNA. And these are our 2023 goals. We're working on many things such as 3D printing reimbursement, the RSNA ACR 3D printing registries to support our reimbursement efforts, guidelines for when 3D printing is appropriate. We're working with the FDA on regulations for 3D printing at the point of care, and we're focused on webinars such as the one we're having today. So with that, I'm going to turn the floor over to Dr. King, and he's going to share with us how 3D printing is being used to change how cardiac surgeons prepare for the operating room. Thanks, Dr. King.
Oh, great. Thank you so much, Dr. Wake, for that introduction. Let me go ahead and share my screen. Okay. All right, so my topic today is advancing the practice of pediatric cardiac magnetic resonance with 3D printing, a clinical perspective. And hopefully I'll be able to show you how we're using 3D printing as well as other imaging techniques to help improve pediatric cardiac care. So I don't have any financial relationships to disclose, and off-label use of Fermax will be discussed. So really my objective today is to help understand how advances in cardiac MRI, advanced visualization, 3D printing has improved the care of pediatric patients with congenital heart disease. And we'll go over 7 cases. So hopefully that'll give you guys an idea sort of what we've been doing. So I'd like to talk a little bit more about cardiac MRI. This is actually a very useful clinical modality because it allows us to look at a lot of different things. Cardiac MRI allows us to look at cardiac function, cardiac flow, anatomy, and also characterize the myocardium as well. So practically, what does this mean? So we can take a look at how the heart muscle is squeezing. We can sort of see how the valves are opening and closing. It also allows us to do some type of flow quantification as well. So how much blood flow is going across a blood vessel or valve, how much is leaking. It can give us an idea with holes in the heart, how much extra blood flow may be going to one place or the other. It can allow us to look at vascular anatomy, and this is particularly important in patients who have congenital heart disease. And it can also help us look at how the tissue help us understand the myocardium or the heart muscle tissue. So whether this could include looking at scar, patients who have myocarditis or some inflammation of the heart muscle, and also help us look at some different types of cardiomyopathy as well. Okay, the pictures I'm going to show you guys, we've obtained through MRI. So this is a scanner that we're using. So we're scanning on 3T using a GE 750W scanner. So we're using a software DV26. For the infants and small children, we use a 16-channel GEM flex coil. And for the adults, we use a 32-channel anterior cardiac coil. So I'd like to start with this first case here. So this is a 4-year-old patient with a murmur. On the left, we see this patient's chest x-ray. So it looks like the heart looks sort of large. And there's also, it looks like there's increased fluid in the lungs as well. And on the right side, we can see the EKG that shows that it looks like that right side of the heart does look hypertrophied. So these are some standard echocardiograms. Let me put on my pointer so you guys can see what I'm looking at here. So this is showing that right ventricle, this is showing that left ventricle, and that right ventricle just looks very thick over here. And this is this is the orthogonal view, so a cross-sectional view showing that left ventricle and right ventricle. So again, very thick right ventricle. Patient also has a dilated coronary sinus over here. So what does that mean? So this is showing a 4-chamber view, so where we can see the left, so we can see the left atrium, left ventricle, right atrium, right ventricle. So the heart function looks normal. Again, that right heart does look a little bit thick there. And this is looking at the aortic arch. So exactly, what is going on with this patient? This patient was referred for a cardiac MRI, and so this shows some comparable views that we've seen previously. So this is showing sort of short axis of that left ventricle and right ventricle, and on the right side we can also see a comparable view of that left ventricle and right ventricle in a long axis type view. So this is showing some 40 data sets here. So these look very similar compared to previous. So the idea with 4D flow is one can acquire a 3D data set with all the cardiac phases incorporated, and then retrospectively you can reformat the structural pictures or the flow pictures in whatever planes one would like. So on the left side, this is showing a 4-chamber view, and then on the right side, this is showing the same 4-chamber view with color. And you can sort of see with the heart filling, there's some acceleration across both the mitral as well as the tricuspid valves. So with that 40 data set, we can look at things in a more interesting way here. So here, this is looking at a sagittal oblique view here, and on the right side we can see the superior vena cava as well as the inferior vena cava, and it looks like there's a defect over here. So this is showing a patient with coarctation of the aorta. So you see narrowing of that aorta there, and you can also see this sort of jet that's going across that tiny lumen, and it's sort of bouncing through here in the proximal descending aorta. And here we're also seeing a superior sinus venosus atrial septal defect. So sometimes these atrial septal defects, they're very, they can be difficult to see by echocardiography. And with this atrial septal defect. We can look at this with velocity mapping as well. So this is sort of a neat way, I think, to sort of visualize how the blood flow is moving through the heart while everything's beating. And then here we're incorporating streamlines as well. So we can see blood flow going across these partial anomalous veins. So pulmonary veins that normally drain into the left atrium instead draining into the superior vena cava. And we also see blood flow going across that atrial septal defect as well. So I'll point it out here. So that's the atrial septal defect that you can see where the arrow's pointing. And then with the pink arrows, we can see the anomalous pulmonary veins as well. So this allows us, so we can quantify how much blood flow there is. So this means that the lungs are getting 2.9 times as much blood as the body is, and with this type of technique, we can tell that 66% of the left to right flow is from blood flow going across that atrial septal defect, and 33% is blood flow from these anomalous pulmonary veins. So with this, so this is showing the 4D flow data set. Now I'm moving to the 3D whole heart data set here. So this is a 3D isotropic acquisition, and we can see a coronal reformat. We can also see a sagittal reformat as well. So this gives a really nice view of what the blood pool looks like in the heart as well as outside of the heart as well. And this is showing the 3D print here. So, so this is a really nice way to visualize where the anomalies are. So with the orange circle, this is showing where that coarctation of the aorta is located. With the pink arrow, this is showing the partial anomalous pulmonary veins draining into the superior vena cava. And then this yellow this yellow geometry is showing where that sinus venosus atrial septal defect is. So, the patient underwent surgical repair and was discharged in 4 days. And essentially, we were able to comprehensively evaluate this patient's complex anatomy with 2 MRI data sets. So what kind of imaging techniques are we using to look at the cardiac structure and function and flow? So first of all, we're using a 3D whole heart sequence with ferumoxetol. So ferumoxetol, this is being increasingly used in patients in the congenital heart disease population. And the nice thing about it is it's an intravascular contrast that extends scanning time. It has a half-life of 13 hours. And we're also able to apply an inversion recovery pulse, and that's able to suppress the myocardium. So hopefully we can try to make things dark, and then we can try to maximize the signal and contrast of that blood pool. And so in practice, what this allows us to get is a 3D data set that has high contrast, high spatial resolution, and high temporal resolution. And the 4D flow data set. So the principle here is we have a pulse sequence that has a magnitude data set and 3 velocity data sets. We're able to use acceleration to try to minimize the scanning time into something that's clinically usable. And this allows us to evaluate cardiac structure, cardiac function, cardiac valve function, and blood vessel abnormalities in a single data set. So on the right side, this showing on the top side, we can see the conventional 2D phase contrast imaging, and then on the bottom we can see the 4D phase contrast imaging. So you can see your spatial resolution is better. And on the bottom right-hand corner, we can see where blood flow is going antegrade, and we can also see precisely where that pulmonary valve is leaking as well. So how about scanning smaller? So this is a 3-day-old patient with low oxygen saturation. So the patient's upper extremity saturations are 65%, and the patient's lower extremity oxygen saturations are 80%. So has some type of reverse cyanosis. Patient doesn't have any murmur, and there were some questions about the echocardiogram. That's why the MRI was done. Okay, and so this is showing the 4D flow data set here. So, so as a heart, we're rotating the heart. We can see that that the right ventricle is anterior and the left ventricle is posterior, and then the right ventricle gives rise to the aorta, and then the left ventricle is giving rise to the pulmonary arteries. So it's nice to be able to visualize this in a very sort of a intuitive data set where we can see everything at once. And this is the same data set with color flow. So we can also see blood flow going across that aorta and also going across the pulmonary artery. And sort of what's going back and forth is that PDA. So, so this is also a sort of a neat way to visualize things. At the end here, we can also see that there's a very small ventricular defect towards the apex of the heart also. We can also get really nice pictures of the internal cardiac anatomy as well. So this is showing a sort of a long axis view, a 4-chamber view, a short axis view, and then also a 3D view here. And here we can also see that there's a left to right shunt across the that atrial septal defect. So there's blood flow going from the left atrium to the right atrium. And then we can see bidirectional flow across that ventricular septal defect as well. So, so this is a nice way to look at things. But this also allows us to get some quantitative information as well. So we can calculate where the blood flow is going, I think, from the systemic veins and pulmonary veins across the tricuspid and mitral valve, and also flow across the aorta and pulmonary artery. And so essentially this gives us a QPQS, or pulmonary to systemic blood flow ratio of 4.8 to 1. So not only is the 4D flow a qualitative technique, it's a quantitative technique. And with the numbers we see here, the totals are very similar. So we're able to self-validate this data. Now here we can see that the patient had a single coronary artery arising from the left anterior sinus. And so we're able to resolve even very small structures in this 3-day-old patient with transpositional grade artery. So that was the key reason for getting the MRI here. So, that patient did well during surgery. I wanted to show you another case where we're scanning in greater detail. So this is a 2-year-old patient with a blowing murmur. So this is showing the patient's echocardiogram here. So on the left side, this is showing the 4-chamber view here. So we can see that mitral valve looks very thick. It looks like that left atrium and left ventricle, they look dilated, and it looks like there's a lot of leakage or regurgitation of that mitral valve. So this is looking at a peristernal long axis view. So again, showing very thickened myxomatous mitral valve with leakage here. And we're even able to get a 3D echo of that mitral valve on FOSS. So this is showing that anterior leaflet, and this is showing that posterior leaflet as well. So this patient was diagnosed with severe mitral regurgitation. The valve was abnormal enough that the surgeons wanted additional imaging to better define the mitral valve anatomy and help plan this patient's surgical repair. So what should a mitral valve look like ideally? What would the surgeons see? So there's an anterior leaflet, there's a posterior leaflet. So you have different scallops, A1, A2, A3, P1, P2, and P3. So that's looking at the valve leaflet, but you also have these chordae tendineae that are connecting to papillary muscles. So what kind of things might make the valve leak? So one thing that could be wrong is that the mitral valve, that the valve could be prolapsing, meaning that the leaflets are sort of bowing into the left atrium. Another thing that could happen is there's some rupture of these chordae, and you can have a flail leaflet. And then the other, another reason why valves might leak is simply, that annulus. The cross-sectional area of that mitral valve is just too dilated, and that can cause leakage as well. I just want to show you guys. So this is our data set. So this is this is using ferumoxytol. We used a 40 flow data set. We were able to get a spatial resolution of 1 by 1.2 millimeters and a temporal resolution of 22 milliseconds. So this is showing the short axis view, and this is also showing the 4-chamber view. So the 4-chamber view is showing a very dilated left atrium, very dilated left ventricle, and we can sort of see there's a systolic dephasing jet showing significant mitral regurgitation. This is showing the right atrium, tricuspid valve, and the right ventricle in comparison. So with this 4D data set, we can do an inverted surface rendering of the study. And here we can sort of see very dilated left atrium, very dilated left ventricle as well. So this is a modified 2-chamber view here. So this is showing the mitral valve. This is showing that I'm sorry, this is showing the left atrium. This is showing that mitral valve with that thickened myxomatous leaflet. And we can also see there's almost too many papillary muscles here, multiple papillary muscles. So we can see the papillary muscles as well as the chordae as well. And here we can see short axis. So we can also see that mitral valve opening, and then when it's closing and squeezing, we can also see that dynamic regurgitation jet, and you can see there's multiple clefts here. So I'll go ahead and freeze everything for you here. So here we can see there's multiple clefts in that posterior mitral valve. So this one, we went ahead and did a 3D print, trying to pull out, I think, that mitral valve. So this is showing a short axis view, looking from the atrium. This is looking from the end, looking from the ventricular side. And here we tried to separate the parts here. So at least with our data set here, it wasn't. I don't think the signal, I think, was good enough, I think, to really, I think, capture, I think, the detail of that abnormal mitral valve. So that's what we had looked at here. So what did we do with information provided from the MRI? So the patient had undergone mitral valve annuloplasty. They had undergone closure of the posterior mitral valve leaflets. They went ahead and did an edge-to-edge repair in an Alfieri stitch. And the result was the patient had mitral valve regurgitation that was reduced from severe to mild, and the patient did not have any stenosis. So the MRI was able to identify all the mechanisms causing mitral valve regurgitation and also proposed a surgical strategy as well. So case 4. So this is a patient who has a detransposition of the greater arteries with an atrial switch operation. So in this case, what happens is the superior vena cava and inferior vena cava are baffled over to the tricuspid valve and right ventricle, and then which connects the aorta. So what could be going on here? So I'll let this play a couple times, and hope maybe you guys can see what's going on here. All right, and then the other part is the pulmonary veins. Pulmonary veins, they're baffled over to that tricuspid valve to right ventricle, the aorta. So we'll play that there. Okay, so I think a couple of things, I think what we're seeing here. So this is the normal configuration of detransmission of the great arteries, okay? And then this is showing the atrial switch operation. So this is showing the superior vena cava and the inferior vena cava being baffled across the mitral valve to left ventricle. And then left ventricle sends blood out to the pulmonary artery. And then the pulmonary veins, they're baffled over to the tricuspid valve, and blood flow goes from the right ventricle over to the aorta. So in this case here, we can see there's discrete narrowing of the systemic venous baffle here. Okay, and that's what's causing the issues. So here's showing, I think, that narrowing of that systemic venous baffle. from a sagittal, axial, and coronal view. And then with color, you can see there's significant acceleration at 2 meters per second across this stenotic baffle. Okay. So this is where 3D printing can be helpful. So indeed, what does anatomy look like? And if one's to try to solve this problem in the cardiac catheterization laboratory, potentially, what may be one's approach. So you can see that the sort of the 3D sort of spatial relationships are a little bit complicated, and so this is the 3D print of that patient's MRI. So let me go ahead and pull this here. So this was the proposed procedure. So one would go through the inferior vena cava, poke across that baffle, do a 270-degree loop, okay, and then go across that tiny hole, and then one would go ahead and balloon dilate and stent this area. And this is showing that cardiac angiogram here. So you can see that the balloon is being inflated and deploying a stent, relieving that obstruction. So this patient did very well after that surgery. Okay. So how about another set of cases? So this is we have a 7-week-old patient with double outlet right ventricle with a L malposed great arteries. So this is showing the 3D data set here. So I'll let it play once, and I'll sort of walk you guys through this. Okay, so we can sort of see. So there's a single right coronary artery here. This is showing the aorta. This is showing a stenotic pulmonary valve with a narrowed right ventricular outflow tract here. And this is showing the ventricular septal defect over here. So the question is like, well, how do we get that? Will that hole connect to the aorta? So this was unusual enough anatomy that our surgeons wanted to get an MRI to try to understand what things would look like. So this is showing the 3D print here. And so this is showing that single right coronary artery. And then when we open this, this is showing the so the left ventricle is here, that ventricular septal defect is here, and this is showing the right ventricle giving rise to both the aorta as well as the pulmonary arteries. So using both the MRI as well as the model, we're able to define that the VSD, the ventricular septal defect to aortic baffle was possible, and we were able to identify a single right coronary artery, which was also a potential hazard in the operation should that right ventricular outflow tract become too narrow. And so this patient had the left ventricle to aortic baffle. That was done. They did a pulmonary valvotomy, and the patient did well. So this is just showing the 3D reconstruction. So this is a case where the 3D whole heart MRI and also the 3D print was helpful in helping the surgeons understand that trying to do this biventricular repair was possible. Okay, so how about this case here? So this is a patient who has a double outlet right ventricle with a D malposed side-by-side grade vessels and remote VSD. So here I'm showing the echocardiogram. So sort of sweeping, I think, posteriorly to anteriorly, showing the left ventricle, and this showing the right ventricle, this showing the tricuspid valve. This showing that ventricular septal defect. And then we can see the pulmonary valve, and we can also see the aorta as well. Okay, so this is showing the 40 flow data set here. So this is showing flow going across that ventricular septal defect. So most of it looks like it's going across that pulmonary valve. The aorta looks quite small, and then this is showing the 3D whole heart data set. So we went ahead and constructed a 3D model for this patient. So this is showing the sort of the outside of the blood pool. So we're looking at see that very large right ventricle here, and then we can see the pulmonary artery. I'm sorry, we can see also the pulmonary artery here, and we can also see the aorta here. We can open the heart, and we can see the left ventricle that's posterior, and we can see the right ventricle that's anterior, and this is showing that ventricular septal defect. So so it's seen here, and we can see the aorta. So the trick is, can one construct a baffle from that ventricular septal defect to the aorta without causing any problems? This is showing that very large pulmonary artery. And so the nice thing is, so this is showing us just using some pipe cleaners to show the passage between the left ventricle across that ventricular septal defect out to the aorta. So with this, it looked like it was too far of a distance. So the patient, they felt doing that baffle and doing a biventricular repair would be quite difficult, and the patient went down a single ventricle pathway. Okay. So let me show you. So let me show you this case, which will be our final case. So this is a 4-year-old patient with inverted ventricles, a ventricular septal defect, no pulmonary valve, and Glenn shunt. So this is showing our 3D data set here. So this is what we would be looking at here. And then this is showing this patient's anatomy. So looking from the external part of the blood pool, you can see the left ventricle looks like connects to the right ventricle. The right ventricle connects over the aorta. The patient has the SVC connects directly to the pulmonary arteries, and this is looking at the inside of the heart. So you can see the right atrium connects to the left ventricle, and then there's a ventricular septal defect that allows blood to go out connect to the right ventricle and then out to the aorta over here. So there are multiple ways to try to fix this. So one thing would be trying to do a Fontan operation. So essentially one would connect the inferior vena cava to the right pulmonary artery with a Dacron tube graft. One could also do a physiologic repair. So this was sort of attractive because it looks like, I think both the ventricles look like they're pretty good size. So one could theoretically do a LV to PA conduit, and then one could close that ventricular septal defect. Okay, so that would be the second option. And then potentially the most aggressive option would be connecting using that left ventricle to pump blood out to the aorta, and then the right ventricle to pump blood out to the pulmonary artery. So this would incorporate atrial switch operation, an LV to aortic baffle across the ventricular septal defect, as well as a right ventricle to pulmonary artery conduit. So potentially, this would be a good short-term result. And then this one is riskier, but has potential long-term results. So after looking at everything, the surgeons had decided to go with the Fontan completion. So in this case, having a 3D model essentially allows the surgeons to get a really good idea about what may be reasonable, to try to achieve the best outcome. Okay, so just to sort of bring it full circle. So cardiac MRI allows us to look at function, flow anatomy, and tissue characterization. Advances have allowed us to look at things, potentially, particularly looking at whole heart data sets, and we can look at things together as well. So this is a very powerful technique. Okay. So cardiac MRI, it's an established tool for evaluating pediatric heart disease. 3D and 4D techniques have significantly increased the utility of cardiac MRI in patients with congenital heart disease. And 3D printing using MRI data sets is a powerful tool for understanding complex cardiac anatomy and determining the best repair strategy. So I'd like to acknowledge my partners at the Dallas Heart Center at Cardinal Glennon Children's Hospital, the Glennon Imaging Department, 3D Printing Center, our Department of Anesthesia, Neonatology, Critical Care, and also the Cardinal Glennon Foundation. So I'd be happy to take any questions you guys may have, and thank you very much for your time.
Thank you, Dr. King, for presenting these excellent cases. You showed some really nice multicolored printed models and case examples of 3D printing in pediatric cardiology and how they can be used for patient care. So thank you for that. I have one question to start with. For the multicolored models, what printing technology do you generally use to make these?
Yeah. So for the multicolor ones, we're using a Stratasys J750 printer. So
okay.
Yeah.
And then you showed a lot of MRI examples. So do you create the models from the MRI mostly?
Yeah. So at least with our current mix of technologies, particularly for the patients, I think with very fast heart rates, MRI works a little bit better for us. So we use MRI a lot to develop some of these 3D printed models.
Yeah, that's really great. And do you have any image resolution requirements or recommendations for 3D printing with MRI? I know it can be more challenging than what we typically use, which is CT.
Yeah. So I think usually with a 1.5T with our 3D whole heart, we can usually get an isotropic resolution. I would say our limit is probably about 1.4 millimeters. And then for our 3T, we can print down to 1 millimeter spatial resolution.
Okay, perfect. Thank you. And we have a couple of questions from online. Dr. Ken Wang is asking, he said it would be great to hear more about particular challenges and strategies related to modeling and printing thin structures like valve leaflets and the atrial septum, especially in neonates. Do you have any more information about that? Challenges or strategies?
Yeah. So I think imaging, thin structures, it's a challenge. Because you have to not only, I think, optimize your spatial resolution, you have to optimize your temporal resolution and not keep the keep the neonate in the scanner for too long. I'm not sure I have a great answer for that. I think with MR, I think one thing I think that's important is trying to keep the heart rate I think as even as possible, and I think that seems to help, but that is challenging both with 3D whole heart and 4D flow techniques.
Okay, thank you. Also, one more question from Dr. Wang. He's curious if you ever find it useful to print at greater than anatomic scale, for example, for neonates, or do you prefer to print only at anatomic scale to preserve the absolute size of these small structures?
Yeah, so that's actually a really interesting question, because I was thinking, it's like, well, gosh, with 3D reconstruction, we can make it as big or as small, as they want, and so we were printing at size, I think, for a long time, but then for a few of them, we thought, it's like, oh gosh, this looks really small, so we printed it at twice the size, which is and the surgeons loved it, so it was really easy, I think, for them to take a look at things. Now I think that was sort of interesting, because you figure that the surgeons are usually like looking at things through magnification anyway. So that was a learning lesson for me.
Yeah, that's really interesting. Thank you. I don't see any more questions online. I have another question. In your institution, this is something like the SIG has been actively working on, but how do you pay for your models? And do you submit for reimbursement at all, or does the department just cover the cost?
Yeah. So internally, we've been generously funded by our foundation, so they've been able to help support the operations laboratory. What we have been doing, I think, with external institutions, is billing through the OR. So essentially, we would charge we would charge, I think, under the DRG. So if patient was undergoing, some surgical operation, so that would just be used as a tool for the operation.
That makes sense. And do you print a lot for external institutions outside of St. Louis, or it's like other institutions that are within your hospital kind of network or umbrella?
Yeah. We've been printing primarily for organizations under the same umbrella. So we're part of SSM Health. So we've been printing for some of the other sister ministries.
Yeah, that makes sense. Thank you. Another question from Dr. Wang: how much do you use functional flow data from the imaging as part of the structural modeling? For example, how much does the flow information help to define the structure of ASD or VSD?
Yeah, I'm not, so in terms of direct 3D printing, I don't think the flow information, has been quite as helpful, partly because I'm not sure I've seen I found the button to print flow yet. But I would say, I think, to your initial question is like, how good is MRI in defining some of these very thin structures. So I think that's where, I think looking at very thin structures like atrial septal defects, trying to figure out sort of what the contour of the hole is, how large the rims are. I think having both data sets available, to give the interventional cardiologist an idea whether this hole is closable. I think that we found that to be very valuable.
Cool, thank you. And I guess, how do your interventional cardiologists or surgeons decide when a model should be printed or if a model might be helpful? Do you have a way yet to determine that?
Yeah. So usually, if there's something that's pretty complex, or there may be, I think, some difference in opinion on whether one surgery or another surgery can be made. That's where that's been helpful for our surgical operations. So oftentimes, I think, like double outlet right ventricle, for instance, where we're really trying to understand that patient's specific anatomy is really helpful. Another thing that we've also found to be helpful would be patients who have multiple uropulmonary collaterals. So you have the lungs that are being supplied by these random blood vessels, that are rising from the aorta, and that's been something else that's been helpful. Certainly, I think for that, I think we're relying, I think, more on CT and rotational angiography data. For the cath lab, so I would say, I think a lot of the things, I think, sort of come to devices and approaches and stuff. So oftentimes, we'll show them the pictures, have a discussion with them, and then if they feel that 3D model would be helpful, then we'll go ahead and make the model for them.
Has there ever been a time when you showed them like a virtual picture, and then they decided after that they don't want to print a case?
I think so. Sometimes that's the case. So I think if it's strictly looking, I think, at the cardiac anatomy itself, I think the 3D models, can be really helpful. I think if sometimes, I think for them, I think just scrolling through, I think, like the CT and scrolling through the MR data sets, I think if that gives them a good enough, I think, sense of the anatomy, we may not print it. So
fair enough. And have you used any other printers other than the J750?
Yeah. So for teaching, some of the teaching cases, we will use the FDM, consumer, type printers, and sometimes we also will use SLA as well. So I think particularly for cranial facial, they really like the SLA because it's pretty quick, it's pretty cheap, and there are sterilization protocols available.
So at your institution, you do other types of models as well, not just pediatric cardiology models, but all types, like you just mentioned, the craniomaxillofacial.
Yeah. So I would say our biggest I think users would be craniofacial surgery, or orthopedics and cardiology.
Okay, cool. Thank you.
You're welcome.
Well, I don't have any more questions, and I don't see any more in the chat. So I think with that, I would like to thank you so much for presenting today. I think those are really excellent cases and great uses of 3D printing, especially in pediatrics. So thank you for being here and for presenting.
Great. Thank you for inviting me.
And have a good day, everyone.